That's a tricky situation because there are already two effective drugs that are very similar in this space, the apalutamide and enzalutamide. These have been established for, at least for apalutamide, probably about a year prior to the publication of the darolutamide study. And enzalutamide has been used for metastatic CRPC dating back to, I think, 2011 or so. So there's a lot of clinical experience with both of those drugs. Whether or not this is an improvement is very difficult to know. I think there are a lot of hazards to doing cross-trial comparisons, so I would caution against doing that. I think it would be reasonable to say that all three of these drugs improved metastasis-free survival. There may be slight differences in terms of effectiveness between them that we cannot yet compare because there's been no head-to-head study. And there may be some differences in adverse event profiles. Perhaps that may be the trigger that might help the clinician and the patient decide between these three agents when all three are considered together for the patient with M0CRPC.
So you're thinking that the toxicity profiles would be the differentiating factor between choosing between them?
They may be. I think that clinicians are going to be drawn to perhaps looking at the differing hazard ratios for benefit as well as the differing adverse event profiles, and that may help with the decision making. I think certainly there are other aspects that we could consider, such as the financial toxicity of these therapies. But by and large, these category of drugs seems to be similarly priced with a similar sort of impact for patients. So I don't think that's necessarily what's going to drive selection of the agent. I do think that the other drugs, you do have a head start in terms of use, already established use in practice.